Thank you for viewing this educational program. This presentation discusses androgen deficiency in the male, also known as andropause or male menopause. Androgen deficiency, also called hypogonadism, refers to a condition in men who have symptoms caused by a decrease in testosterone production. This decrease in testosterone production is sometimes referred to as andropause or male menopause. We now know that some men's bodies do not make enough testosterone. These men may experience uncomfortable and sometimes distressing symptoms. It is estimated that there are 4 to 5 million American men and approximately 500,000 Canadian men who may suffer from low testosterone, but unfortunately only 5% are currently treated. Testosterone is the male hormone produced in the testicles. In the male body, testosterone is the most important sex hormone, just as estrogen is the most important sex hormone in women. Testosterone is responsible for development of male characteristics such as body and facial hair, muscle growth and strength, and a deep voice. Normal levels of testosterone also influence the production of sperm and promote sexual function and sex drive. Testosterone is also responsible for growth and development of the prostate gland. The pituitary gland, a small gland located in the brain, controls the production of testosterone from the testes or testicles. The pituitary gland regulates the testes via 2 hormones, luteinizing hormone and follicle-stimulating hormone, which are also known as the gonadotropins. The pituitary gland is under the control of a nearby area of the brain called the hypothalamus. Lower levels of hormones result in deficiency of testosterone production. Testosterone deficiency means the body is exposed to lower than normal amounts of androgens, particularly testosterone. The effects depend on how severe the deficiency is, its cause, and the age at which the deficiency begins. When related to aging, androgen deficiency is sometimes called male menopause. This is a misleading term because it suggests that, like women, all men experience a dramatic drop in hormone production. This is not correct, but testosterone deficiency is more common in older men. This illustration shows how testosterone deficiency can occur. If there is a lack of production of LHRH, a releasing hormone, from the hypothalamus, there is a decrease in the luteinizing hormone, or LH, from the anterior pituitary gland, and therefore a decrease in production of testosterone from the Leydig cells in the testicle. This process is signified by the first X in the graphic. The second X demonstrates the effects if there is a decrease in the production of LH by the anterior pituitary gland. If so, there is a decrease in the stimulation of the Leydig cells and a decrease in production of testosterone. Finally, if there is a decrease in the Leydig cells in the testicle, there will also be a decrease in the amount of testosterone produced, and thus a testosterone deficiency. The symptoms associated with testosterone deficiency include a decrease in the size or mass of the muscles and thus a subsequent loss of strength. Another common manifestation is a loss of libido or sex drive. Erectile dysfunction or impotence, which is a decreasing ability to obtain and/or maintain an erection adequate for intercourse, can also occur as a result of testosterone deficiency. In younger men, testosterone deficiency can affect the ability of the testicles to produce sperm and therefore result in infertility. Testosterone also affects the central nervous system or the brain and can impair ability to concentrate or even affect the memory functions of the brain. Testosterone deficiency can also cause the bones to soften, producing a condition called osteoporosis, which can, in mild cases, cause a loss of height and in severe cases result in fractures of the spine and hip bones. Testosterone is also responsible for maintenance of the hair follicles, and a deficiency can result in the loss of body hair. Symptoms of low testosterone can also include a decrease in energy level, motivation, and self-confidence, which can be manifested as lethargy and by diminished work performance. People may also experience sleep disturbance, falling asleep after meals, increased body fat, and hot flashes. Your doctor may ask you to complete a questionnaire, which may be helpful to make a diagnosis of androgen deficiency. To see if you are at risk for low testosterone, answer yes or no to the following questions. If you answer yes to question 1 or 7, or at least 3 of the other questions, you may have low testosterone. Be sure to discuss the results of this quiz with your doctor. A diagnosis of androgen deficiency, or hypogonadism, is made by evaluating the symptoms of low testosterone that were discussed previously. A history of these symptoms would include decrease in energy level, decrease in libido, erectile dysfunction, loss of muscle and bone mass, and sleep disturbances, which include falling asleep after meals. Your doctor will then perform a physical examination and will probably examine the testicles for size and consistency. He may perform a digital rectal exam to evaluate your prostate gland and look for signs of decreased testosterone, such as loss of body hair. Blood tests are performed to help determine the amount of testosterone in the blood. Blood is usually drawn and measured on 2 separate mornings. Drawing blood in the morning is important because it will detect the body's peak levels of testosterone. Pituitary hormones may also be measured. There are various methods to measure the serum testosterone level. Perhaps the most common is the total testosterone level. Most men with levels of testosterone below 300 nanograms per 100 cc's of blood are considered to have androgen deficiency and might benefit from treatment. Other tests may sometimes be required to determine if testosterone deficiency is due to another underlying medical condition. This may include blood tests to check for iron levels, genetic tests, or imaging such as CT or MRI to scan the brain. Semen analysis can also determine the potential fertility of men with androgen deficiency. Androgen replacement therapy, or ART, should be started after a diagnosis is established and contraindications have been excluded, such as prostate or breast cancer. For men older than 50 years, untreated prostate disease should be excluded by a digital rectal examination, or DRE, and measurement of blood PSA level. Injectable testosterone is the long-time standard treatment and is the most cost-effective. Injectable products release testosterone gradually into the bloodstream. Weekly or biweekly injections are desirable to approximate a normal blood level of testosterone. Longer spacing leads to fluctuating blood levels and unpleasant symptoms when the blood levels of testosterone drop below normal. Transdermal testosterone patches are a suitable alternative to injectable testosterone. Transdermal therapy requires the delivery of small amounts of testosterone daily. Patches may cause skin irritation, but if tolerated, can be a very satisfactory long-term option. Other transdermal delivery systems, based on creams, gels, and sprays, are less irritating and more cosmetically acceptable, but may be more expensive. Oral testosterone is generally not recommended because it may cause liver damage. On the horizon are testosterone implants, which are inserted beneath the skin in the abdominal wall or in the skin over the buttocks. These testosterone implants have the advantage of being able to sustain a normal testosterone level for up to 6 months. The major drawbacks to the implants are the need for a minor office-type procedure and the risk of extrusion or forcing out of the implant through the skin, which occurs in about 10% of implantation procedures. The side effects of testosterone replacement therapy are not common once levels are restored to the normal range. Some of the possible side effects include weight gain, mild acne, mood changes and increased aggression, male pattern baldness, and breast development. Older men may experience problems with urine flow if prostate growth is stimulated. Patients with current or suspected prostate cancer should not take testosterone replacement therapy. Prostate cancer should be carefully ruled out before initiating testosterone therapy. There is little evidence that using testosterone in men without prostate cancer will eventually cause prostate cancer. However, there may be a reluctance to using testosterone in men who are at risk for it. For instance, men with a first-degree relative with prostate cancer, or in men with a slightly elevated prostate-specific antigen, or PSA level. For men not at increased risk of prostate cancer, there is no evidence that testosterone replacement therapy will cause it to develop. There are several studies that suggest that certain men who have been treated for prostate cancer and who have a PSA level that is near zero or who have a stable PSA level after treatment can receive testosterone, providing they are carefully monitored. This needs to be discussed carefully with your doctor. Although rare, men with breast cancer should not use testosterone replacement therapy. There is no contraindication to testosterone replacement therapy in men who have heart disease risk factors such as hypertension, elevated cholesterol levels, coronary artery disease, angina or chest pain, or abnormal heart rhythms. Patients who are receiving testosterone replacement therapy require regular visits to the doctor. Men over age 50 will need an annual digital rectal examination and a PSA test to check for prostate cancer. Men will also need periodic blood tests to check the serum testosterone levels, complete blood counts, a cholesterol level, and perhaps liver function tests. While androgen deficiency may not be life-threatening, it has significant and important effects on the development and maintenance of masculine sexual characteristics and the function of so many other organs and tissues. This may lead to a decrease in quality of life. Most of the symptoms of androgen deficiency are easily correctable by simple and cost-effective treatment using hormone replacement therapy. This slide lists some of the many resources available where you can find more information about androgen deficiency. These current references were used to assist in the preparation of this module. All of these are available through your local medical library or the internet if you are interested in more detailed reading on this subject. Thank you once again for viewing this educational program. Talk to your doctor if you would like more information about your condition.